Shall I start, guys? Sudeshna?
Yes.
Yes.
Okay. Well, good evening, everybody, and welcome to GoRed, its first initiative in India. My name is Dr. Sunita Maheshwari, and I'm going to be one of your moderators for this evening. I'm a pediatric cardiologist, so I only look at the fetal part of pregnancy, but I was trained at Yale University in New Haven and moved back to India 20 years ago. I have to say, as a fellow in pediatric cardiology in the US, the American Heart Association played a big part of my life. I got the Young Clinician Award there over 22 years ago. So when they were coming to India with this initiative of the Heart and Stroke Foundation and asked me to get involved, I was more than delighted. As you know, the AHA in the US and all over the world has been very active in training, and the Heart and Stroke Foundation, which is a subsidiary of the AHA in India, is aiming to do the same. So the aim is to have training and technical support for governments, for healthcare workers, for hospitals, and for communities. Now, the GoRed initiative in the US was an initiative for women. We always talk about, women wearing red, but this wasn't just about the color. This was really about their hearts. And so today evening, I wore my little heart earrings for you. But the GoRed initiative is for women's heart health. And I'm really pleased and honored to be presenting GoRed's first webinar in India to all of you who have logged on. So I think without further ado, I'll move on to the scientific part of this. So we're going to basically have 3 presentations. The first 3 are going to be on pregnancy, and then there will be a panel discussion and question and answers. So if you have any Q&As, you can put them into your chat box, and those questions will reach the panelists. Following that, we'll have the second panel, and that panel will really be on cardiovascular disease risk. So we'll move from pregnancy to cardiovascular disease and prevention, and that will be followed also by a panel discussion and a Q&A. So with that, I would like to introduce the first panel moderator to you. So I hope I get this right. It's Dr. Elena Camel. She's an associate professor of clinical obstetrics and gynecology at the Feinberg School of Medicine at Northwestern University. She's also the founder of one of the first all-women's OB/GYN groups in Chicago. Her areas of special interest are hysteroscopy, permanent contraception, osteoporosis, gynec surgery, menopausal health concerns, and twin pregnancies. So I'd like to thank AHA, HSFI, and the GoRed initiative for bringing Elena's expertise to us here watching in India. So I'll now hand over to you.
Thank you so much, and good evening and good morning to those of you in the US. This is really a very exciting event, an exciting day. We have some very special speakers with lots of very important things to share with us. So I think everybody will walk away from this presentation with lots of new, interesting information, especially during our COVID pandemic. We are very lucky to have Dr. Goldstein, who will share some information on his work. It's really important for all of us to be engaged, not only in heart disease for women, but also in looking at the correlates of obstetrics and the impact of what happens to a woman during her pregnancy in her future years for heart disease. And that has been really a very large focus of ours, is to link and educate both OB/GYNs and internal medicine physicians on the implications and how important what happens in pregnancy impacts women the rest of their lives. So without further ado, I would love to introduce our first speaker. Dr. Anne Marie Valente is the section chief at Boston Adult Congenital Heart and Pulmonary Hypertension Program and associate professor of medicine and pediatrics at Harvard Medical School. Her research interests focus primarily on identifying non-invasive risk factors in patients with complex congenital heart disease. Much of her work involves patients with repaired tetralogy of Fallot, including leading an international registry of tetralogy of Fallot patients. Dr. Valenti co-directs the Pregnancy and Cardiovascular Disease Program at the Brigham and Women's Hospital and leads several investigations in women with congenital disease during pregnancy. So welcome, Dr. Valenti, and we look forward to hearing your talk.
Thank you very, very much. And I just wanted to confirm that people can see my slides.
Yes, we can see your slide, Anne-Marie.
Thank you. Well, first, thank you to the AHA for including me in this terrific session. I'm excited to be here and learn with you. I do not have any disclosures. So my objectives are to recognize the impact of cardiovascular disease on maternal mortality. And to do this, I'd like to provide an overview of the hemodynamics that can occur during pregnancy, women with heart disease. I'm going to focus on primarily three groups: women with valvular heart disease, with congenital heart disease, and with forms of cardiomyopathy. So why are we talking about this? Well, we're recognizing that cardiovascular disease is a major cause of maternal mortality. This graphic is showing you the inquiries from the United Kingdom several years ago, and indirect deaths are listed in the solid bars, and you can see that cardiovascular disease is the #1 cause of death. Similarly, in the United States, we know that cardiovascular disease is a leading cause of pregnancy-related mortality, and in fact, the numbers are rising with more than 17 deaths per 100,000 live births. So it's so important when we think about this and pregnancy values for certain factors. So if we start with plasma volume, shown here in red, we know that women experience a great increase in their plasma volume, and it really peaks in the end of the second, beginning of third trimester. You compare that to something like stroke volume, which also rises significantly, up to 30% in most women, but that change happens much, much earlier. You can see many women are just learning they're pregnant early in the second trimester here. Heart rate, shown in orange, also increases, often about 10% from pre-pregnancy values, but some women, especially those who've undergone heart surgery as a child, may not be able to have that heart rate response. Looking at cardiac output, shown here in purple, that also surges up to 50% of pre-pregnancy values, following a timeline similar to that of the stroke volume change. Now, as we look at these factors, the one factor that definitely decreases during pregnancy is the systemic vascular resistance. We think of the placenta as a huge afterload reducer. So that's why women with certain cardiac conditions, such as valvular heart disease, oftentimes may do okay. But we recognize that these hemodynamics dramatically change during labor, delivery, and the early postpartum period, and we have to see that as a time of major risk for women with heart disease. We think of the placenta, and that's why it's been so beneficial that over the past several decades, there have been several maternal risk classification scores that have been developed. I'm sharing with you here one from the European Society of Cardiology, published in their guidelines, which is the modified World Health Organization classification, just focusing on those women with greater risks. You can see here the class 3 and class 4. Class 4 being patients who are at the highest risk. These conditions won't surprise you. Women with ventricular dysfunction, with pulmonary arterial hypertension, and with severe forms of congenital heart disease, such as systemic right ventricles, single ventricles, left-sided obstructive lesions. Women with connective tissue disorders, also at a very high risk with aortopathy, and symptomatic left-sided valvular obstructive lesions. The last thing that's listed here is critically important. It's the functional class of women. We know that a woman's functional class going into pregnancy will very much dictate how she does throughout that pregnancy and her risk. The group in Canada has spent several decades looking at risk stratification models. And Dr. Silversides and her colleagues recently updated this CAR-PREG score in the CAR-PREG 2 study, where they included almost 2,000 pregnancies in women with heart disease. About 65% of these women had congenital heart disease. Another 23% or so had acquired forms of heart disease, and the rest had mainly arrhythmias. So some conditions are underrepresented in this model, but they found overall a 15% chance of having a maternal cardiac event during pregnancy. That was usually heart failure or arrhythmia-related complications. They were able to generate a risk calculator, and you can see here the highest weighted risks, which get a point of 3, are women who have had a prior cardiac event, poor functional class or cyanosis, or those with a mechanical heart valve. A risk score of 3 would equate to about a 15% risk of having a maternal cardiac event during pregnancy. If your risk score is over 4, you have more than a 40% risk of having a cardiac event. Dr. Silverside's group was then able to take this data and actually look at a subset of over 1,300 pregnancies to identify severe cardiac events. These would be women who had a cardiac arrest, death, needed to be in the ICU for heart failure, or needed urgent intervention. And what was striking about this data was that they determined that almost half, 49% of these events, are truly preventable. And you can see here in this graphic, the reasons that women were mismanaged was oftentimes a failure of early recognition of the problem or a delay in treatment. So it should be our goal as providers to try to decrease and alleviate these events. So when we look at different cardiac conditions, structural heart disease is so important, and there have been several studies in rheumatic heart disease. This one that was recently published out of Puducherry looked at 820 pregnancies in 681 women with rheumatic heart disease. And interestingly, over a quarter of these women were diagnosed with their heart disease during their pregnancy. The most common cardiac lesion was mitral regurgitation. And of this group, 15% experienced an adverse cardiac outcome, the most common of which was heart failure. Dr. Bagal and colleagues were able to generate a risk score specifically for women with rheumatic heart disease. And you can see the higher weighted points here for, again, prior event, severe mitral stenosis, and pulmonary hypertension. And indeed, if your risk score was 5 or higher, you had a much greater risk of having an adverse outcome during pregnancy. So what do we do? Well, thinking about the management of women specifically with mitral stenosis during pregnancy, it can be very tricky. And this was some interesting data recently published by the group in New Delhi, which showed the success of percutaneous mitral balloon valvotomy. This was a small group of women, 24. Just over half of them had had a valvotomy within 4 years prior to pregnancy. The other half had their valvotomy during pregnancy, usually during the second trimester, and they did very well, showing the safety of this procedure when needed. Now, in the AHA-ACC guidelines for management of valvular heart disease, we know for women with mitral stenosis during pregnancy, we try to first medically manage them, and certainly if they're in an arrhythmia, it's a class 1 recommendation to provide anticoagulation. We oftentimes try to lower their heart rate to prevent complications, so beta blockers for these women are a class 2A indication. Diuretics, when needed for volume control, is a lower class recommendation. But we really reserve the invasive strategies for those women that are refractory to medical treatment. The heart disease guidelines also are recognizing the increased number of women living with mechanical heart valves that become pregnant. And there is newer recommendations on management for these women. Class 1 recommendations are shown here in this graphic in green, and we understand that these women need to be extremely closely monitored. Class 2A recommendations in yellow, we are now advocating to continue warfarin dosing for women with mechanical valves if the dose can be kept to less than 5 milligrams a day. And then you adjust the anticoagulation strategy right before delivery, and then again, meticulous follow with measuring of levels if you're using heparin. Thinking about another group of women which are increasingly becoming pregnant is our women with congenital heart disease. And this was another recently published retrospective review from New Delhi looking at 55 pregnant women with congenital heart disease. Now, I should mention these authors did exclude women with severe forms of congenital heart disease and Eisenmenger syndrome. In this group of women, about half of them had never undergone an operation. The other half had previously undergone an operation, and they had very similar baseline characteristics. In fact, the majority of these women lived with shunt lesions, atrial or ventricular septal defects, or some form of valvular pathology. The outcomes were quite good, and there was really no difference in maternal cardiac or obstetric complications in these groups, just highlighting that many women with congenital heart disease do well throughout pregnancy. Now, I'd like to switch gears for just a minute and recognize the importance of peripartum cardiomyopathy as we care for women. This graphic by Dr. Sliwa recognizes that there is normal remodeling that occurs during pregnancy, and the heart changes. But after pregnancy, the vast majority of women return to a normal cardiac hemodynamics. However, there might be some insult, and there are several listed here, whether it's a nutritional or infectious or some other abnormal signaling that creates a situation where women get peripartum cardiomyopathy. Then they may return to normal function, or they may have irreversible dysfunction. And this graphic is just highlighting some of the pathways that are being recognized in this process. And there are now therapies targeted to retard or stop peripartum cardiomyopathy, such as using bromocriptine to prevent prolactin secretion, thus limiting the apoptosis that occurs. We know that women who have peripartum cardiomyopathy, their prognosis is based on their presenting ejection fraction. This graphic is a study from the investigators of pregnancy-associated cardiomyopathy, and you can see here in the red line, these are women who had a left ventricular ejection fraction of less than 30%. They definitely had more events. These investigators followed women with serial echoes during pregnancy, and then at 2-6 months postpartum, as well as 1 year postpartum, 13% of them went on to have an adverse event. That's death, transplant, or need for an assist device, and or had a progressive lowering of their ejection fraction to less than 35% at 1 year. What was interesting with this data was that no women who had an ejection fraction less than 30 or an end diastolic dimension greater than 6 centimeters recovered their function completely. So with that, I just wanted to mention the importance of the pregnancy heart team. We're going to be talking a lot about this today. This graphic is from a recent scientific statement by the American Heart Association, and Dr. Mita will be talking to us later, but it's just highlighting that we don't do this in isolation. It's so important to recognize that in working with women, it's not just the 9 months or so of pregnancy, but it's really throughout their lifespan, and I'm anxious to learn more about this today, and the great collaboration we have with our maternal fetal medicine and obstetric colleagues. So it's there that I'm going to close and mention that cardiovascular disease is really a leading cause of pregnancy-related mortality. Heart failure and arrhythmias are the most common complications in women with underlying heart disease, and preconception counseling and involvement of a pregnancy and heart disease collaborative team will improve maternal outcomes. Thank you so much for inviting me to be part of this session. Thank you to my partner, Dr. Economy, in our program, and all of our collaborators in our STORK effort. Happy to take questions.
We will actually take questions at the end of the session. Thank you so much, Dr. Valente, for that wonderful talk. And I hope people will send in questions for us when we have our session. I would like to now move to the placenta and talk about placental pathology in COVID. We are thrilled to have Dr. Jeffrey Goldstein with us this morning. Dr. Goldstein is an assistant professor in the Department of Pathology at Northwestern University in Chicago. His prior scientific work has included studies of the placenta and drug repurposing in gestational diabetes, also artificial intelligence diagnosis in the placenta and mechanisms of muscular dystrophy in model organisms. His work with the AHA has been funded kindly, and we are excited also to hear a little bit of his most recent work during the pandemic and with placental pathology. It is really an honor to introduce someone from my same department to all of you. So without further ado, Dr. Goldstein, we'd love to hear from you.
Good morning. Can everyone hear me okay? Yeah. Thank you, Dr. Campbell, and thank you to the AHA and the Heart and Stroke Foundation of India for inviting me here. I appreciate the opportunity always to speak to the AHA. I have no disclosures. So, I think that no one needs to be convinced of the importance of the pandemic, but I think that some people needed to be convinced of the importance of the pandemic, particularly in pregnant women. And we know that recent pandemics have had major impacts over pregnancy and lifelong. So, we asked ourselves, could COVID-19 cause a more severe disease in pregnant women, as we saw in the 2009 H1N1 flu? Does it cause fetal anomalies, as Zika or CMV did? Or could we have perhaps lifelong outcomes, such as the decreased lifelong income and increased risk of cardiovascular disease that we're seeing in the 1918-1919 flu pandemic? So what do we know? And I think that other speakers are going to be going to this, so I'll try to be relatively brief. We know that in pregnancy, it does not seem that so far that women have more severe disease. The rate of ICU admission, about 3%, is comparable to that for non-pregnant women that are sort of similarly aged. In the systematic review that I saw, there were no maternal deaths reported, although there have been maternal deaths reported elsewhere in the literature. The preterm birth rate was 20%. A fair bit of that is driven by the experience in Wuhan, where women with coronavirus pneumonia, that was considered to be an indication for early delivery. That's not really reflected in the data that we're seeing at our institution. Cesarean delivery rate was high. Again, I think that a lot of that is driven by those early deliveries. Vertical transmission rate, perhaps 0%. I'm throwing a lot of asterisks on there because there are some fairly well done case reports that show some positivity. I will tell you, we had one infant that tested swabbed positive for COVID immediately after delivery, but then was swabbed again and was negative. I think the interpretation of that is very challenging. But I would say that the vertical transmission rate, true vertical transmission, so transmission through the placenta prior to delivery, is quite low. And the neonatal death rate also seems to be quite low. Next slide, please. So, why do we think the placenta is important? So obviously I'm a placental pathologist. I'm going to try to convince you of that. I would argue that the placenta is the cause of and record of most of the diseases of pregnancy. So if we think about hypertensive diseases of pregnancy, like preeclampsia, hypertension, and abruption, which can be related to that, those we see maternal vascular malperfusion changes in the placenta. And depending on pathogenesis is a little bit complicated, but sort of failed invasion of the placenta can be a part of that. We see gestational diabetes, which is in large part driven by endocrine hormones secreted by the placenta, fetal vascular malperfusion or cord accidents, and then chorioamnionitis. The placenta is not necessarily causing it, but it certainly is showing a record of that in the form of acute inflammatory pathology. May I have the next slide, please? I'm not going to really hover on the embryology of the placenta, but we know that early in gestation, the zygote implants within the endometrium and starts to differentiate. So the placenta is the first organ to differentiate. It really starts to tap into the maternal circulation to provide oxygen and nutrients to the fetus. Can I have the next slide, please? Is there one missing? I think there might be one. Oh, there we go. And then the fetal structure is here. So this is sort of diagrammatic. I'm not drawing the fetus, but you can see the umbilical cord. So you have two arteries containing deoxygenated blood and one vein returning oxygenated blood. Those sort of spread off across the surface of the placenta and then divide and branch, somewhat like the airways in the lung. And then those villi are surrounded by maternal blood, which comes up through the spiral arteries at the basal plate. And can I have the next slide, please? So what did we see in our cases? So our paper, we reported 15 cases. We've had probably another 50 or 60 patients deliver since then with, I would say, a fairly similar profile. And then we compared them to two sets of controls. We had patients with melanoma or history of melanoma, and those patients, because that's unrelated to pregnancy or other diseases of pregnancy, those patients may be more reasonable controls for otherwise healthy women who contract coronavirus. And then we looked at a larger pool of all of our historical controls, which is about 17,000 patients. The rate of preterm delivery, I think you can sort of get a sense of why we like the melanoma controls a little bit. So the rate of preterm delivery in our cases was about 7% or 1 out of 15, comparable to melanoma controls. And of course, the historical controls, a much higher group. About 40% of our cases were small for gestational age. But if you look at our melanoma controls or our historical controls, those are also frequently small for gestational age in the placentas. I think that's got something to do with our norms. We had one case where the placenta was large for gestational age, and that's sort of consistent with what we see historically. 2 of our patients had a history of asthma. 1 had pregnancy-induced hypertension. 1 had cholestasis of pregnancy, and 1 had gestational diabetes. And those rates are probably comparable to what we see historically. The ascertainment is a little bit different here, so it's not entirely comparable. But I would say that generally speaking, these are not terribly complicated pregnancies. A lot of these placentas are not placentas that would be sent to our lab to examine routinely. In terms of our cases, 9 of the 15 patients had COVID symptoms, most frequently fever or cough. 6 patients were asymptomatic, and they were picked up on universal screening, which we initiated and picked up some patients. 2 patients needed oxygen use. We had no ICU admissions and no maternal deaths. The APGAR scores at 1 minute were all 8 or 9 for the infants. APGARs were at 5 minutes were all 9. So that's the best. So the sort of early post-delivery was very good. At the time that that's not assuming of it. So the infants were all discharged within 4 days, except for the infant that was born preterm, and that infant was delivered at 34 weeks and was discharged at day 15. So in other words, almost as soon as possible. This is very good short-term outcomes. Can I have the next slide, please? I think that I could talk about the pathology for a really long time, and I wanted to pick sort of one thing to focus on for our audience, and one thing that I thought would be sort of speak to a cardiology-focused audience. And so I'm showing you a micrograph of decidual vasculopathy. So the sort of gray material all around, that's the decidua, so that's the maternal stroma. And in the middle is a maternal blood vessel. However, we have the lining has been replaced by this pink material, this bright pink material, which is fibrinoid. And then you can see these sort of clear foamy cells in there, and these are the lipid-laden macrophages. And so, of course, a cardiology-focused audience or cardiovascular-driven audience will recognize that this looks a bit like atherosclerotic disease, maybe a bit more acute because these don't have as long to develop. But that sort of vascular injury is what's going on here. And just as atherosclerosis causes decreased blood flow to end organs, this decidual vasculopathy is associated with decreased blood flow into the placenta, and from the placenta, decreased oxygen delivery to the infant. And so we know that in the short term, these kinds of findings can be associated with small for gestational age infants, oligohydramnios. They can be associated with intrauterine fetal demise, although we did not see any cases of that. And then in the long term, there are some recent studies that show that this kind of vasculopathy is associated with maternal cardiovascular disease, decades later. May I have the next slide, please? But more broadly, what did we find? So I showed you the decidual vasculopathy, which was our main finding. We did not find a unique pathognomonic lesion of COVID-19. That's not surprising. The placenta doesn't tend to do that. It has a few sort of reactive patterns. This is one of them. But we do see this decidual arteriopathy. This is maybe related to this thrombotic tendency in COVID that has been sort of well recognized. I talked about the atherosclerosis. I want to take a step back and talk about other work because we found this decidual arteriopathy. We thought we were the first paper to be published. There's actually one paper that was published slightly before ours. In their case, they didn't see the vestigial arteriopathy. I've reviewed a couple of additional papers, as a reviewer that were submitted that also did not show the vestigial arteriopathy. And so we are looking at more patients, and we're going to try to decide if we still agree with ourselves. There are a couple of cases of second trimester fetal demise, and we reported one as well, which I haven't really talked about because we didn't really see anything unusual in the placenta in that case. And so it's hard to know if that was a coincidence. I could say that we have not seen since then more second trimester IUFDs, which is reassuring. There are a few cases that show active viral replication in the placenta, specifically in the syncytial trophoblast. And as I think I mentioned, we have a larger case series going that we're working on. But as I think everyone else is, we're spending a lot of time trying to survive the pandemic at this point, and then hopefully we can do some science in between. And I think that's my last slide.
Great, thank you so much. Really very interesting work. And I know that those of us who are practicing obstetrics will have lots of questions for you for our first and second trimester patients as the pandemic continues. I would like now to introduce my dear friend, Dr. Usha Sriram, and I would like to remind her that actually 2 years ago, both Dr. Volkman and I had the pleasure of being her guest in Chennai at a wonderful meeting that she ran with her organization, DUAS. So this really is extra special to introduce her today on the anniversary of our lovely visit to India. Dr. Usha Sriram is an American board certified endocrinologist and also has board certification in internal medicine. She's been practicing endocrinology for 25 years in the United States and in India. In particular, we had the pleasure of having her work at Rush Medical Center for many years. In addition to her role as a physician, she is the founder of an amazing organization, the DUAS, and director of Aster Health. Women's reproductive health has been an area of her expertise and passion, and she addresses critical issues like gestational diabetes, polycystic ovarian syndrome, menopause, and non-communicable disease in women. She was a huge loss for us here in Chicago, but has been an enormous blessing to those in Chennai and to the people that she interacts with all over the world. Usha really is an amazing physician and really is so focused on women's health. We really are thrilled to have her here today, and she holds a really special heart in our hearts and with the AHA.
Thank you, Elena. Those are extremely kind words. Thank you so much. And what a pleasure it is to see you and Annabelle today. I want to thank the American Heart Association. Very grateful to them for doing this program and also asking me to speak on this particular topic, which is very important, especially in these days. I have no disclosures. Can we go to the next slide, please? Next slide. So I just want to start with this particular cartoon, which clearly tells us three things. One is, as women get older, the plasticity, or for that matter, anyone gets older, the plasticity goes down. High plasticity during infancy, and then as we get older, it goes down. And then healthy women or women who have had early interventions, you can see, stay below the threshold for disease. And the opposite is true for women who have either complicated pregnancies or there have been no interventions. Next slide, please. So this particular table shows us if a woman has had a baby who's born in the lowest birth weight quintile, what is her future risk of death from ischemic heart disease? And as you keep adding the risk factors, if it is low birth weight plus preterm birth, it goes up much more. And then if you add preeclampsia to that, everything goes up exponentially. Next slide, please. So who are these high-risk women? Women who have had miscarriages, women who have had a baby with fetal growth restriction, preeclampsia, preterm delivery, overweight and obese women, and especially excessive gestational weight gain, gestational diabetes, subfertility, and thrombophilia. Next slide, please. So we need to start viewing pregnancy as a stress test, because as you can see, there's insulin resistance going on, there's an upregulation of inflammation, increased GFR, some lipid changes happening. It's a hypercoagulable state. So really, it's an unbelievable, unidentified window of opportunity to improve long-term both maternal and infant health, and that's what we're going to talk about the next few minutes. Next slide, please. So I want to look at this in the context of three new concepts. One is what I call clinical myopia. The next one is reverse Barker hypothesis. We all know Barker hypothesis. And the third one is, of course, window to future health. Next slide, please. So the first one is clinical myopia, because we always look at pregnancy in the context of the immediate outcome of the current pregnancy. So preconception, prenatal, and interconception focus on pregnancy outcomes, and the health of the baby is usually not there. The health of the mother may be seen only in the context of threat to the baby's well-being. And of course, we miss opportunities to address women's health longitudinally. Next slide, please. So this reverse Barker hypothesis, next slide. So we all know the brilliant scientist, Dr. Barker, who introduced us to the fetal origin of adult disease, fetal origin of cardiovascular and lung disease, and also brought into the radar of everyone how the first 9 months shape the rest of our life. Next slide, please. And he also said the womb may be more important than your home. And from the seminal work of the original group, you can see the prevalence of non-insulin dependent or type 2 diabetes and impaired glucose tolerance in men by their birth weight. And then if you see women, effect of birth weight and adult weight on the metabolic syndrome in women. And here I just want to point out, it's not just low birth weight, it is also what happens to the adult BMI. So this whole concept of mismatch. So if you're born small and then you get big, your problems are that much larger. Next slide, please. Next slide, please. Yeah. So reverse Barker, previous slide, please. Sorry. Reverse Barker hypothesis is physiologic adaptations during pregnancy. They unmask a woman's predisposition to diseases. That's why this concept of stress test. Complications are increasingly predicted by first trimester algorithms. They amplify a pre-existing maternal phenotype and accelerate risks for chronic disease in the offspring up to adulthood. That is the Barker hypothesis. But then what the recent evidence is showing is the vice versa is also true, which is pregnancy diseases also indicate maternal and even grandparents' risk for future chronic disease. Next slide, please. So what are these future chronic diseases we are talking about? Of course, cardiovascular disease is large. Next slide, please. So when you're thinking about pregnancy, we're really looking through a very critical window. Pregnancy acts as a window into future maternal health. Pregnancy provides a window to identify disease at its earliest stage, and the postpartum period is a window of opportunity to access longitudinal care. And then the postpartum period should really be the start of primary prevention of diseases for which the risk has been identified during pregnancy. Next slide. Really quickly, you can keep pressing the next button. So it shows that when a pregnant woman has gestational diabetes, and if she has an infant who happens to be a girl child, she is not only at risk for future type 2 diabetes, she's also at risk for future gestational diabetes. And more recent evidence is saying that the ova of this infant is already bathed in the high glucose of the grandmother's blood, and therefore that baby is also at risk for future metabolic problems like diabetes. So it's not only transgenerational, it's multi-generational. Next slide, please. And so when you look at NCD risk in the mother, with each subsequent pregnancy, if the first pregnancy has gestational diabetes, the risk goes up. If the next pregnancy has gestational diabetes, and we know the chances are really high, you can see it puts this woman in a high risk trajectory. And the same thing for NCD risk in the offspring. So this is really a great window of opportunity. Next slide, please. So this is for hypertension. When there is preeclampsia, not only there's endothelial dysfunction and other metabolic abnormalities, inflammation, oxidative stress, all of which is then leading to future hypertension. Next slide. And this is something that is really important, which is gestational weight gain. With each subsequent pregnancy, the weight gain just keeps increasing, predisposing or putting this woman at a tremendous risk for future type 2 diabetes, cardiovascular disease, metabolic syndrome, chronic lung disease. Next slide, please. So we need to actually have some care paths and care models where we are addressing preconception care, where we are addressing how we need to recognize these abnormalities or these complications that are happening during pregnancy and postpartum. And if you want me to summarize it in just in a nutshell, we cannot let these women out of our sight. We probably need to keep them on keep following them up and identifying the risk factors and putting in the preventive strategies. Next slide, please. So I'll stop with this just to say that next month we are launching our app, which is Be Ready, which is a preconception care, because we really believe that if we want to decrease the burden of these complications during pregnancy, we need to start preconception. Thank you so much. Thank you, Elena.
Thank you. Thank you, Usha. Really very insightful and so meaningful for the future of women. So thank you for that wonderful talk. So it's now time for us to invite back our three speakers. So love to have Dr. Valenti, Dr. Goldstein, and Dr. Shuram available for questions. And we do have some questions that have come in from the audience. So I'd like to start with those. And then if there are more that come in from the chat, please feel free to do so. So one of the questions first was to Dr. Valenti. Can you give us a little insight of how do you work within a cardio-obstetric team, please?
Well, thank you very much. I'd love to talk about that. I am really fortunate that our team in Boston is comprised of more than 20 people from all aspects of the healthcare team, and we work closely as cardiologists with the obstetrical team, and specifically I co-direct the program with Dr. Kathy Economy. We have some standards that we use to ensure that we are providing the best care we can. So we meet once a month with a conference where everyone comes, nursing and physicians and care coordinators, and talk about each woman, and we assign a level of risk. We have risk for obstetric risk, anesthetic risk, and cardiac risk. And I should mention Dr. Jeannie Carabueno is our obstetric anesthesiologist, who is always so helpful. We actually designed a color coding scale, which we've now made part of our record, so that each month we're able to determine the risk based on some of those risk scores I talked about, but also based on our team consensus experience. And then we manage women as far as their diagnostic testing and need for follow-up based on their level of risk, recognizing it may change throughout the pregnancy. I think having the coordinated meeting is important. We try to enroll each of our women that are willing into our standardized protocol so that they get serial testing and follow them beyond delivery as well. So we see them back in the postpartum period, but just as we've learned, so important to continue to see them, then we're somewhat of the referral people to refer them out to care as needed, which is more and more. So it's a wonderful experience. I think the success of it is that we are always available. So if I am not available right now, one of my partners is taking the calls, and the similar way for Dr. Economy's team. And we've just beautifully learned how to communicate with each other, but we have to be there for our patients and for providers 24/7.
Great, thank you. Dr. Goldstein, we have a couple questions for you. So one question was, should we be starting low molecular weight heparin antenatally in patients who are COVID, who are at risk for COVID? And then a general question is, as more is becoming known about COVID, what do you see as emerging areas of research? So let's start with those.
Those are both really great questions. I mean, for the first question, you really should not ask a pathologist about treatment. What I would say is that we are seeing patients, with COVID diagnoses on low molecular weight heparin, and that is one of the things that we're looking at is if patients are treated, do we see lower rates of either decidual vasculopathy or another lesion that I didn't talk about, which are just thromboses in the placenta, which is actually less scary than it sounds. In terms of the more urgent areas of research, I think there are really two, which I think are pretty clear. The first is, what's happening in early pregnancy. The nature of just when the epidemic hit and how long gestation takes means that in the US, we have not had a chance to really see what happens, in the second and third trimesters to women who are infected in the first trimester. And I should say that a part of that sort of scientifically is that we are doing a lot of nasal swabs for our screening. But if someone has been infected in the first trimester, they may have just thought they had a cold. They may have been asymptomatic. We know that in Zika, asymptomatic patients can still have birth defects related to that. And so we need to be moving to a perhaps longer lasting test. So antibody, I know that antibodies do clear, but that's something that we have thought about. And then the second is, I think Usha was sort of pointing toward was the lifelong question. And so looking at developmental outcomes, at least in the short term, as well as maternal cardiovascular markers after delivery.
So thank you, Jeff. You actually answered the next question, which was someone in the audience was very concerned about, does COVID show potential for causing long-term complications for offspring? So I think that that's something that all of us in the medical profession and also in the basic sciences, we need to look for, because I think it's an unknown at this point. Certainly we are using anticoagulation postpartum in someone who is nasal swab positive. I don't think that there's anyone yet who has looked at using antenatal low molecular weight heparin. There are people who anecdotally are using aspirin or baby aspirin in patients who have tested positive in the second and third trimester, but that is all at this point anecdotal. And then to the cardiology team, one more question. It was the following: beta blockers may affect outcome of the baby, then how to use it as a rate controlling medication in the COVID environment?
Sure, I'm happy to take that one. I think we're learning about the COVID environment right now and what best to do, recognizing the risks that are present. We do use beta blockers for rate control. We ask that the fetal growth is followed more closely. Certain beta blockers we find are better tolerated for the women and also seem to have less impact on the fetal growth. But that a lot of that is very small experience. So especially for lesions where you need to control the heart rate to have time for diastolic filling, we find that beta blockers from a maternal standpoint are the most effective. But clearly, there needs to be a shared decision-making from the mother that she understands the risk to the fetus.
Usha, help us motivate our colleagues, and how do we create a health history, their family history, so that we can make a dent on the outcome of their pregnancy and future pregnancies?
So I missed a part of the question. Would it be possible to repeat that?
Sure. How do we go about starting a program that we're about to do, where before a woman's pregnant, we have the opportunity to sit down with her and have a discourse and take a history and plan a pregnancy rather than backpedal once the patient's pregnant?
So that was my last slide. I was showing you that we are launching this program called Be Ready, and it's a self-assessment program. So the trick is going to be, how are we going to get the women to come and get engaged in that? And I'll talk about that very quickly. And then how do we get our OBGYN colleagues to make this standard of care? Unless this becomes standard of care, preconception care. So this is a 20 point checklist. So the women go starting from anemia to health history, heart health history, folic acid, hypertension, diabetes, smoking, STIs, the whole thing. So it's a 20-point checklist. And what happens is they go through this checklist, and at the end of it, they get a health history report card. And the report card is given in, red, amber, and green. So the idea is she takes this to her healthcare provider. And in India, we also have a large number of people called ASHA workers, who are the frontline health workers. So they take care of women in the rural areas and women who live far away from healthcare facilities. So this self-assessment can be also administered by a frontline health worker. So it can be an app, it can be a printable form, it can be done on a tab, it can be done any way, and the woman can take it herself. So once she does that, the goal is to make all the reds and ambers go green. And once everything goes green, she's ready for pregnancy. So we're just working on making this somewhat exciting and fun for a woman and not medicalize it too much. And then promote this and hopefully through Foxy and FIGO and ACOG and others. It's a global instrument. So if they can take it on, then this will become standard of care. So how we did this was when we looked at this with road testing the self-assessment program. What we found was majority of OBGYNs want this, and majority of women don't do it. The women who want to get pregnant, 50% of pregnancies are unplanned. And even in the ones who plan, it's really not planned. They want to get pregnant, but they have not planned their pregnancy, as in gotten ready for it. So
we really look the pregnancies being more planned. So Usha, this app looks very exciting. Hopefully we'll be able to bring it over to our country and to
August 9th.
To everywhere. One last question. Do any of the speakers have questions for one another? Would you like to ask one another any questions before we move on?
So there was to Dr. Goldstein, a really quick question. There was a report from Italy, I think yesterday, about vertical transmission and also presence of COVID in breast milk. So I was a bit disturbed upon seeing that.
That is disturbing. I think that, when you look at reports of vertical transmission, you have to be very careful, because there is, if babies are, staying in the room with the mothers, there's a very high rate of what's called horizontal transmission. In the case, I think if you're referring to the same case that I saw, that looked like a real vertical transmission case where there was coronavirus in the placenta sort of crossing it. I think that's concerning. If you're thinking about the case that I'm thinking of, this was a patient with pretty severe disease, and the placenta showed a pattern of inflammation called histiocytic enterovillositis, which is extremely rare, but has been reported in a couple of cases of coronavirus. And in fact, there was a reasonably well demonstrated vertical transmission with one of those previously. So I think that may be the pattern here. I think that, as we've seen more cases, it seems that the rate of vertical transmission is very low, but non-zero. And so it makes sense to continue to swab these kids and test them. In terms of breast milk, I didn't see that part. I know that people have been looking at fluids, and that generally speaking, breast milk, vaginal fluid, amniotic fluid have all been negative. And so I think that this is a rapidly evolving field. I always think of back to like HIV, and if you look at the early reports, people are saying like, is it poppers? Is it CMV? Is it this? Is it that? Is it the other? And you sort of have this like slow coming into focus of what is generally true and what may happen occasionally and what is just a coincidence. And I think that I think we're going faster than we were in the 80s, which is good. But I think that the same process is definitely happening.
Thank you.
I will say, anecdotally, we are seeing a lot more second trimester losses than we have ever before. And the real question that we have in our practice is whether this is COVID related. So we're hoping that the placentas are going to be looked at, and we'll serially, obviously keep tabs on it, but it's very strange. I mean, we have had an inordinate amount of second trimester losses, which we don't usually see. So what it's from, we don't know yet, but certainly we are very suspicious that it may be COVID related.
Absolutely. And if you flag those to me, we can look at them.
Absolutely, I will. So thank you, Dr. Sriram, Dr. Goldstein, Dr. Valente, for really a scintillating set of 3 different talks. If people have questions for at the end of our talk, please send it to us. But at this time, I'd like to hand over the microphone to Dr. Maheshwari for our second grouping of wonderful speakers.
Thank you very much, Dr. Camel. It looks like it's a Chicago night. We have Dr. Camel as a professor at the Feinberg School of Medicine at Northwestern, my co-moderator. And now we move on to our speaker, who's also from Chicago, but it's not rhythm and blues tonight. It's Go Red all the way, so not blue but red. So I'd like to now introduce our speaker for the next panel. And this is now not pregnancy related, but the next one is really interesting because it's the effect of obesity on the severity of COVID-19. And for this, we have Dr. Annabelle Santos Volgman. I hope I said that right. She's the co-founder and medical director of the Rush Heart Center for Women in Chicago, Illinois. This is the first heart program in Chicago which is devoted exclusively to women. She's Professor of Excellence in Clinical Cardiology at Rush. She's a nationally recognized leader in cardiology care and research. She's a fellow of the ACC and the American Heart Association, and she's dedicated her career to helping women and their families lead healthier lives through prevention and treatment of cardiovascular disease. So I'll hand over to you, Annabelle, and look forward to lots of learnings in this session.
Thank you so much, Dr. Maheshwari. Thank you, everyone, for joining us today. I want to thank Melanie Turner from the AHA, who leads the International Go Red for Women. Dr. Please go back to my introductory slide, please. Thank you. Next. One slide before. Previous slide. Thank you. Okay, Dr. Lakshmi Mehta and I are on the International Committee of the American Heart Association, and this educational program, as well as the one we did in Pakistan, are some of our activities. So we plan to engage different countries in our efforts to improve the cardiovascular health of women all over the world. So it's my pleasure to be with my esteemed colleagues to speak about the effect of obesity and the severity of COVID-19. Next slide, please. These are my disclosures. Although I have disclosures, I have no conflict of interest for this talk. Thank you. Next slide. So I just wanted to talk about some key facts about obesity from these are previous slide. These are from the World Health Organization. My slide is not showing anymore. Francis, can you please go to slide 3? Anyway, as Francis gets our slides ready, I just wanted to talk about some key facts about obesity from the World Health Organization. Worldwide obesity has nearly tripled since 1975. And in 2016, more than 1.9 billion adults over the age of 18 are overweight. Of those, over 650 million were obese. And 39% of adults, previous slide, Francis, thank you. 39% of adults over 18 years were overweight in 2016 and 13% were obese. And most of the world's population live in countries where overweight and obesity kills more people than underweight. Underweight people used to be a significant risk for death. And this is especially interesting in India, as I will discuss in the next slide. I think for most people, obesity is preventable. Next slide, Francis. When it comes to weight and cardiovascular disease, there is usually a J curve. The underweight and the obese have increased risk, but we also see an obesity paradox. Increased weight compared to underweight can be protective during surgery. This slide shows that there are double the number of women who are obese. 20 million Indian women are obese compared to 9.8 million men who are overweight. However, there are over 100 million Indian men and women who are underweight in India, which comprises 40% of the global underweight population. So it's interesting to see how COVID will affect India, since they do have a lot of underweight people. Next slide, please. The next slide shows two maps. One is women and one is men. And these are age standardized state level prevalence of obesity, which was defined as BMI greater than 30 by sex in India. So the upper map, the A map is women and the lower map is men. And as you can see, and then the gray area was not included in the study. And as you can see, there are areas that have more obesity than in other areas. I believe Tamil Nadu is where my dear friend, Dr. Usha Sriram resides. So as an endocrinologist, I'm sure her patients keep her very busy, seeing that there's a lot more obesity in that area of India. Next slide, please. Dr. Lakshmi Mehta and I, and along with my other co-authors here, decided to lead a statement paper on atherosclerotic cardiovascular disease in South Asians that reside in the United States. We found that although Asians in the US tend to have a lower risk of heart disease, certain Asian groups, such as South Asians, including those from India and Pakistan, have the highest risk of cardiovascular disease among the Asian groups. Obesity and diabetes certainly contribute to that increased risk. Next slide. Obesity is associated with worse prognosis in COVID-19. There is no doubt about that statement. But what are the effects of obesity in patients with COVID-19? This table is a summary of the different effects of obesity when one gets the infection. We see elevated triglycerides, excessive activation of the sympathetic nervous system, and the renin-angiotensin-aldosterone system. And since obesity produces a chronic inflammatory state and hypercoagulability state, this can worsen during COVID. Obesity increases the risk of certain cancers, which can also complicate the care of COVID patients since they can be immunosuppressed. Next slide. This figure is just a summary of the different organs that are affected by obesity that can contribute to a worse prognosis when infected. As you can see, adipose tissue can also serve as a reservoir for the SARS-CoV-2, which is the virus that causes COVID-19. Next slide. In this figure, the right-hand side shows that the adipose tissue has a high ACE2 expression, which can increase the ability of the virus to get into the cells and its ability to replicate. In addition, on the left-hand side of this figure, it shows that increased adipose tissue leads to an increased angiotensinogen. When ACE2 receptors in the cells are not available due to the virus binding to it to get into the cells, this increased angiotensinogen can lead to vasoconstriction, inflammation, fibrosis, and oxidation. Next slide. There have been over 300 articles in PubMed published as of yesterday on the effects of obesity in COVID. And this disease just started in December. So 300 publications on just the effect of obesity on COVID is a remarkable number of papers already published. This study is will show in the next 3 slides, will show the results of a systematic review and meta-analysis of over 200 articles already published when they did this study. So next slide. This is from Beijing, China. So as you can see, they evaluated over 180 papers, and only 9 articles were included in the quantitative analysis, since there were some duplications and there were some non-good quality parts of the paper, so they excluded those papers. And so they came up with 9 papers that were used for the qualitative analysis. Next slide, please. This slide shows a forest plot of BMI in severe versus non-severe COVID-19. As you can see, it shows that severe COVID-19 was associated with a higher BMI. Since there was some heterogeneity, the investigators did a sensitivity analysis in the right-hand side, labeled B, which shows that there is no effect on each one of the study that would change the outcomes of their conclusions. Next slide. This slide is a figure of a forest plot of the 4 studies that looked at the effect of obesity compared to non-obese patients and patients who had COVID. And the results show that obese patients had a more severe outcome with a pooled odds ratio of 2.3. So that's more than double when somebody is obese. Next slide, please. So this last slide is a summary of the recommendations of the Association of the Physicians of India for patients with diabetes and obesity for COVID-19. As you can see, it says that diabetes and obesity are major risk factors for COVID-19. And among the diabetics, these are the risk factors that increase the prognosis, the worsening of the disease. Being male, being elderly, having hypertension, heart disease, and chronic renal disease are more vulnerable to COVID-19. It's important that diabetes management in hospitalized situation merits early diabetes-specific nutrition with insulin, and adherence to a healthy lifestyle with self-monitoring of blood glucose and adequate supply of insulin and oral antibiotic agents are encouraged. Next slide. So thank you again for joining us today, and thank you to the AHA and the Heart and Stroke Foundation of India. Thank you.
Well, thank you very much, Annabelle. That was quite fabulous, and I'm sure we'll have a lot of questions for you. We'll move on now to our next speaker, who's from Ohio. So we go from the land of rhythm and blues to Ohio, which is famous for its Rock and Roll Hall of Fame. So it's my pleasure to introduce Dr. Lakshmi Mehta. She's a professor of medicine at the Ohio State University, and also the Sarah Ross Sauter Endowed Chair in Women's Cardiovascular Health. So over to you, Dr. Mehta, and she will be taking us through preventive health. Really, what is the GoRed for Women model that has evolved over the years? So over to you, Lakshmi.
Thank you, Dr. Maheshwari, and thank you, HFSI, for inviting me to speak. I'm particularly honored to spread the message on heart disease in women. As a child, when I visited my family in remote parts of Andhra, I saw the focus and concerns of heart disease in men amongst my family members, which really inspired me to go into cardiology. However, my passion for cardiovascular disease in women began when my grandmothers died of acute myocardial infarctions. And so I'm honored to help share the message to our fellow Indians about cardiovascular disease in women. Next slide, please. So I have no financial disclosures, but have a vested interest in women's heart disease, both as a female and as a cardiologist. And I GoRed for women's heart disease prevention. Next slide, please. In the United States, more women were dying from cardiovascular disease than men in 1984. Women are represented in the red line here and men in the blue line, and deaths in thousands is on the y-axis. But after 1984, this difference persisted where more women were dying than men, but there was a significant decline in mortality in men, but not in women up until the year 2000. The medical community slowly began to notice this disparity. So in 2004, there was a launch of awareness campaign, the GoRed movement, which quickly grew into an international movement and has become a platform for real change. Next slide, please. Despite the medical community's awareness of heart disease being the #1 killer of women, the public did not understand this. In 1997, in the United States, only 33% of Caucasian females, 15% of Blacks, and 20% of Hispanic women understood cardiovascular disease as the leading cause of mortality in women. With much of the AHA's awareness campaigns, other organizations, and media, there has been a trend to increased awareness. So now on the far right of this figure, you can see that 65% of Caucasians, 36% of Blacks, and 34% of Hispanics in 2012 are aware of cardiovascular disease, being the #1 cause of death in women and in not being breast cancer. However, there's much more work that needs to be done, and there are racial and ethnic gaps in awareness that also need to be addressed. Next slide, please. So in a recent study, it was shown that 26% of women find having the diagnosis of cardiovascular disease to be embarrassing. And they assume the risk is solely linked to weight and nothing else. So clearly there's a need to destigmatize heart disease risk by countering the stereotypes that are associated with the facts. And only 40% of routine care includes a heart risk check. Almost 40% of primary care physicians make cardiovascular disease a top priority where it really should be top priority for all. And only 20% or so of primary care physicians and 40% of cardiologists feel well prepared to assess CVD risk in women. So there's a need to invest in women's cardiovascular disease research, physician and the medical community's education and training, as well as the education and training of our lay public. Next slide, please. So assessing a woman's CVD risk can be done really in a stepwise format, and these steps are crucial for the medical community and patients to be aware of. So step 1 is screening for the sex-specific risk factors, as you can see in the green step on the left, which is a lot of the pregnancy-related factors that have been discussed today. And then you go to step 2, and so if you want to look for traditional cardiovascular disease risk factors such as hypertension, diabetes, hyperlipidemia, and treat those certain risk factors. Step 3 is really incorporating the American Heart Association's Life Simple 7 for all our patients. And that's really a lifestyle. So managing blood pressure, controlling cholesterol, reducing blood sugar, staying active, eating healthy, losing weight, and recommend patients to stop smoke and obviously avoid secondhand smoke as well is crucial. And then we move to step 4, really assessing the 10-year ASCVD risk of women and also their lifetime risk, and then treating those that are really in the intermediate risk or borderline risk with preventative steps. And definitely the high-risk patients should also be treated. Certainly in the long-term effects of COVID may alter some of the long-term CVD risks. We really don't know what COVID will have from an atherosclerotic process long-term, but we also know that it's really impacted the immediate term in terms of preventative steps. Many people are fearful of going outside and doing the exercise, and so that's impacting some of the preventative steps that we need to see. So we're going to learn much more about COVID's long-term CVD risks in the decades ahead of us. Next slide, please. So next slide. Additionally, the American Heart Association has been on the forefront of promoting timely and pertinent pieces of women's cardiovascular disease. So recognition of the inclusion of women-specific factors in the recent cholesterol guidelines, as well as the rise in maternal mortality in the US, was the foundation for us to write the most recent American Heart Association scientific statement on cardiovascular considerations in caring for pregnant women. And this was just published in May of 2020. Some of my co-authors were also on our webinar today, including Dr. Boldman and Dr. Valenti. A general understanding of cardiovascular disease during pregnancy is core knowledge for both our cardiovascular care team, but also for our primary care clinicians. So in this document, we highlight the need for the cardio obstetrics team, which you heard Dr. Valenti speak about, as an optimal multidisciplinary approach to the management of cardiovascular disease during pregnancy. Documents like this not only permeate to our medical community, but also educate the general public with media exposure that we've been able to provide, and really gets our public to also ask questions and do the preventative steps that are necessary for them. Next step. So when we look at media promotions from the 60s and 70s, next slide, please. Much of the media promotions was really on CVD prevention and how to take care of men's cardiovascular health. It really wasn't up until the early 2000s did the focus switch to women. So in 2003, Time magazine featured women and heart disease on their front cover. And in 2004, the AHA launched the GoRed campaign. Additionally, scientific statements that have had global impact have been important, including our statement on acute myocardial infarction in women. In fact, when this was published in February of 2016, this was also highlighted in various media outlets in India, which is important as we try to expand our GoRed for Women initiative across the globe. Next slide, please. So now when we go back to mortality curves, you can see that there's been a sharp decline in women's CVD mortality rates since about 2000 down to 2010. And in fact, actually the lines have crossed in 2014 and now more men are dying. We don't have all the specifics of why this trend has changed. It's certainly opt for more research that we're working on at the American Heart Association. It's disappointing to see the mortality rates increase for both genders. And so things need to definitely be done to address this, but clearly you can still see gender differences exist. Next slide, please. Shifting gears, the AHA has a 2030 global impact goal, and that is, together with global and local collaborators, we will equitably increase worldwide health life expectancy from 64 to at least 67 years by 2030. Next slide, please. So health life expectancy, as I just quoted, is the number of years that a person at any given age can expect to live in full health. While females tend to live longer than males, many of these extra years are spent in poor health. And in fact, in Southeast Asia, of the extra years, 32% is actually in poor health. And living longer is great, but also living healthy is very essential. Next slide, please. Looking at the global life health expectancy in 2017, the average was 64.8 years. Which by 2030, we hope to increase it to at least 67 years. Some countries are already at this level. However, some countries lag behind, and change needs to be made now. For instance, India's healthy life expectancy is at 59.5 years, which is far below the global average of 64.8 years and far from the 2030 goal of 67 years. So much work needs to be addressed in India, and that is an interest of ours. Next slide, please. So the red dress is the branding behind the American Heart Association is doing to advance and improve women's health on all levels. We have to change the perception of heart disease being a man's only disease, the narrative, and widen our focus to all women and not just some women. And this can be accomplished by accelerating science, advancing public health policy, closing gender and ethnic gaps in research, encouraging more women to go into science fields, and raising awareness in all women and walking hand in hand in women as their trusted health partner across the globe. Next slide, please. Currently, the GoRed for Women International Partners has 54 licenses in 47 countries that span the globe, and we're happy to say that it also includes India. Next slide, please. So this can be accomplished in India as well, the healthy lifestyles and the desire to increase healthy expectancy by partnering with the medical community, having educational events like today for our medical community, but also the message needs to reach the public, and having that grassroots approach that is being done, such as what Dr. Sriram had mentioned in her presentation, are essential to get the message out. Having women talk about women's heart disease is essential. Next slide, please. So this can be accomplished with public health education targeted for women in various geographic parts of India, different religious groups as well. And that we need to get gender-specific patient and provider education, providing in the different languages in India is going to be crucial. And then making sure that when guidelines are developed, that they include gender, and that we also need to remember our obstetricians and gynecology partners in this, because, you know, women's cardiovascular disease spans her lifetime, and certainly we need more female healthcare providers. Next slide, please. And finally, we need to recognize that cardiovascular disease is really a continuum, a lifetime of prevention that starts from early childhood as we age. Pregnancy-related events do provide us a window for the future cardiovascular disease of health of women. So it's imperative for us to be aware of pregnancy-related outcomes, but also work on prevention and our lifestyle throughout our lifetime. So the AHA's GoRed model has promoted preventative health through activism and advocacy. And this has been a successful model for success within this US. And we also hope that we can collaborate continually across the globe to spread it and make it a success globally. Next slide, please. So thank you for allowing me to participate in this important webinar. And remember to go red for women. Namaste.
Thank you very much, Dr. Mehta. That was a wonderful talk. And I think, you know, in India right now, you know, sometimes prevention is hard. We have a lot of cultural issues, like if you're thin, then it's considered that you're actually unhealthy. And they'll be like, you know, feed them a little bit more. Why are they looking so thin? So I think we have a lot of cultural issues in our country to deal with in terms of obesity and prevention. So we'll there's some interesting questions from the audience. So I think the first one is for Dr. Waldman, which is, have any age differences in women been seen regarding obesity and the severity or outcome of COVID? So I guess the question would be, is there any difference between younger and older women, assuming both are equally obese, in terms of their severity with COVID?
That's an excellent question. I didn't see any paper specifically talking about that, but we know certain things. We know that women are not at higher risk for death in COVID-19. Men, for some reason, which is very interesting. We had another talk in Pakistan about the sex differences in mortality and morbidity of COVID-19, and for some reason, men have definitely have a higher risk for morbidity and mortality in COVID. We know that the elderly have a higher risk of mortality, and we know that obesity, but for some reason, women are sort of protected when it comes to mortality with COVID. And that is very interesting indeed. And I think we need to do a lot more research. And we are at Rush actually looking at all of these variability in what causes severity of disease in COVID, whether it's age, whether it's race, because we know that the ethnic groups in Chicago are having, or in the United States, have a higher mortality and morbidity with COVID-19. But is that really a factor of race, or is it a factor of socioeconomic status? That all remains to be answered. And I think there's a lot of effort looking at that right now. Thank you.
Annabelle, can I add something?
Of course.
Dr. Subramaniam from Harvard, he has just shown that, and you brought this up during the Pakistan meeting, that something unusual is happening in Pakistan, that among the women with COVID, their mortality was higher than the men with COVID. So more men are having COVID, so more men are sick and dying. But among the women who have COVID, more of them are dying. And you brought that out in Pakistan. The same thing is happening in India. So Dr. Subramaniam from Harvard has just pointed it out. So it's 2.9 versus 3.3. So if you take all people with COVID, more men, get COVID and more men, die. But the numbers, so they call this as mortality burden versus mortality risk.
So thank you so much for reminding me of that, that Pakistan stood out as one of the outliers in that increased mortality in men in Pakistan. There was not, that was not the case. The numbers for India were not available as of that talk, and they may be more available now. But I wonder if it's the fact that there is so much underweight people in India. I don't know about Pakistan. I think Pakistan tends to have a more obesity than India. But I wonder if it's the number of underweight people that's affecting that higher mortality in women. What do you think?
I'm not sure. There may be other social determinants of health, because usually women do well with these viral, they have better immune systems. They usually do better, but so there may be other social determinants of health, like they may not be getting the care as quickly as they should, or there may be health inequities, even at the healthcare delivery level.
Yes.
Yeah, economic disparities, I think, in India. The same goes for children with things. We did studies looking at male and females in our cardiac ICU. And we had, even though the incidence of, for instance, ASD is higher in women, in the girl child, we had more boys in the ICU. So it's also a little bit where the money goes in terms of who's going to get admitted and get therapy and so on. So fairly complex, I guess, for analysis. So there's another question for you, Dr. Wollman. Should outdoor exercise still be recommended for obesity in view of the evidence suggesting aerosol transmission of COVID?
So the question is, should outdoor exercise be recommended?
For people who are obese and need to be exercising, but
yes,
in view of this evidence of, aerosol transmission,
so
what should they do?
I would think that because of the aerosolized transmission, it's worse to do exercise indoors, and that is why health spas and gyms are still not open in most of the United States, because when you're exercising and breathing hard and sweating and that breathing hard actually increases the aerosolization of that transmission of COVID. So outdoor activities is definitely a much better way to do your exercise. So I hope that answers that question.
Yeah, I think so, yes. We have one more question for you, Dr. Wollman. Obese people, since we know that they're at higher risk for COVID, what can they do to reduce their risk right now? I mean, they can't magically lose weight overnight, but what are some of the things they can do to reduce that risk?
Definitely. So, obesity is definitely associated with diabetes, and Dr. Sriram could better explain this, but of course, the control of diabetes is essential when it comes to this, because it increases the risk of infections when your glucose is not well controlled. But I would recommend the usual recommendations for non-obese patients, which is a frequent hand washing and wearing masks. I'm in Michigan right now, and here in Michigan, it is mandatory. You can actually get fined and get a misdemeanor charge if you don't wear masks when you're in an indoor setting. So I think that the governor here in Michigan has been very, very strict about that. And I think that that would result in better compliance. And it's extremely important for men, for patients with hypertension, for older people, to really adhere to those prevention guidelines, such as wearing masks and frequent hand washing, and really avoiding any social gatherings if absolutely avoidable, if not necessary. Thank you.
Thank you, Dr. Waldman. I think we have a few questions for Dr. Mehta. One is, how does the GoRed movement encourage more women healthcare providers? So I guess this is from a doctor, so from a female doctor.
Sure. So the GoRed movement is largely increased among women providers by encouraging, women wear red. If you see Dr. Waldman every day of her life, she wears red now. So that's one way to encourage. But what the GoRed movement has recognized is that we need to encourage the next generation. And so they're doing programs with high schools, colleges, to promote more women to go into science-related fields. It doesn't just have to be healthcare. It could be the engineering fields, the researchers, to generate that momentum. But one thing I want to make clear is the GoRed movement is not a female-specific provider movement. It is for all healthcare providers. Because we have to recognize women make 50% of the population. And so men are taking care of these patients, or men have sisters, wives, daughters who are also important to them and need this addressed as well. So it's a cross-platform, but encouraging more people is through encouraging the next generation.
Thank you. Another question for you, Dr. Mehta, says, on the map slide, I saw that healthy life expectancy is one of the highest globally in Italy. Does anyone know why? And is there a gender difference in that number?
I'm not sure about the gender difference in the number. We did notice that in Italy as well, and it's hard to say if there's a genetic difference there. Obviously South Asians, we know cardiovascular disease is much higher amongst South Asians, but some of the, is it the healthier lifestyle? Is it the olive oils and the red wine that's protective? That would be interesting. I mean, the best thing to do is perhaps move some of us to Italy and spend the rest of our lives there and do a control study. That's how you would assess for the genetic component, or is it the lifestyle component? But it is an interesting finding. And I also wonder if they're just more of an active kind of society than us as well. But certainly the red wine and the olive oil is contributory along with the genes.
I just wanted to add, actually, Dr. Camel and I were supposed to be going to Italy this summer to give a talk, but of course that is not possible at this time. And just speaking of that, the northern Italy statistics have been horrendous for the COVID. And part of the reason why COVID-19 was so bad in Italy was because of the elderly population. They have so many older people living, and as we all know, elderly people are more affected. So it's interesting to see that the Italians had such a high mortality from COVID because there were so many older people in Italy.
If I could add
Which is
Dr. Mehta, the same statistics were in Australia as the Italians, and so they have different lifestyles. Any insight on why they have such longevity?
I don't think we have that clear of an insight into that as well. And it's really hard to really assess the lifestyles in these different populations, if that's contributory or are they better at managing their cardiac risk factors? Is that the implication? It's really hard to understand and to put our finger on that. But it would be ideal to understand what makes one population better than the other. But for the purpose of today's talk, clearly we need to be stronger in our preventative measures in India, and that's what we hope to partner with you all on.
Dr. Mehta, I'd also want to say that the American Heart Association has done a really strong job in the U.S. Of reaching out to physicians, to residents, and medical students, to really teach these basics, to reteach these basics, and also make sure that they're part of the curriculum. So that could be something that one could extrapolate as a global initiative, is that we have to start very early in the medical population and also in the non-medical. And it's just by continued education, reaching out to where people go, where they congregate, whether it's in a religious place, whether it's in a hometown, whether it's at a meeting with women or families, but it is really grassroots that the AHA has done to try and get this impact of education. Because unfortunately, most women still think that breast cancer is what's going to kill them, and we know that that's incorrect. And so it's persistent education that we have to hammer to get our message across.
Well, and it's true, Dr. Kamal. And the other thing we want to recognize is that it's not just heart disease that we're talking about in these numbers, that it's also stroke, and stroke can be quite devastating and contribute to that unhealthy longevity in women.
And I was just going to chime in also that we are partner, the AHA and the ACC are partnering with the ACOG. So we really need the help of the obstetricians and gynecologists in this effort to educate women. The obstetricians and the pediatricians actually are the ones who are seeing these women early on. So to emphasize heart healthy lifestyle is so important in the young women and men. And I love Dr. Sriram's new campaign, Be Ready. I love the pregnant logo as the bee. That was not lost in me. That was really brilliant. I love that idea of preparing women before they even think about being pregnant to make sure that they're healthy. And of course, we all feel guilty because we had our, milkshakes when we were pregnant. Well, at least when I was pregnant, somebody kept pushing me to drink milkshakes to increase my calcium. So I did for my children, but I would never do that again.
I think to kind of give a little secret, ACOG before COVID hit in February did meet because I was part of this committee. And there will be a template that will be made to look at menopausal women and assess their cardiovascular risk. So this will be an EMR template that will be directed not just to OBGYNs, but also internists. So I think ACOG is definitely on board. Unfortunately, COVID kind of halted us in our tracks, but it is coming, it is forthcoming. And I think it will be very helpful because it will be a triage system, not only asking questions, but also providing websites, educational material for both physicians and patients of how to take steps when patients answer different questions that show that they have risk.
That's terrific.
Yeah, that's great. I think, Dr. Mehta, since you've been on both ends of the spectrum, growing up in Andhra Pradesh and now being in the United States, we have a lot of doctors in our audience. What would you advise them in terms of initiatives for women? How can they reach out? Because as you know, in India, there are a lot of cultural issues. So what would be the best strategies for public health awareness in India? You think, taking from some of the GoRed initiatives in the US, which of those would be easily replicable in India, do you think?
Sure. And to clarify, I didn't grow up in India. I spent my summers in India, but yes. So from my experience, there's a lot of person-to-person communication. So I think the campaign has to start amongst the women itself. So finding women who want to lead this. So in the American Heart Association, what we've done is that finding female survivors. And they help spread their message. They spread their message via in the medical community giving talks from their experience, but also doing media campaigns. And so having them do videos and spreading their message via social media, like what their symptoms were, how they're too young to have heart disease, but they did have heart disease. Things like that can help, because women are going to sometimes more trust a female friend or someone that they can relate to, and not think that it's going to be something that happens at menopause time. And then having our movie industry involved. Many people are very much fixated either with Bollywood or Tollywood or whatever other place in India. And so having those messages through them is also important. And I think the message has to not just reach the women. So when I've gone even to Gujarat for my husband's side of the family, I've seen that even amongst the educated women and men, they're not aware of cardiovascular disease. And they were shocked that it's not breast cancer. And so making sure that we're educating the men, because they help make those financial decisions of when a female sees a doctor, or when she, what kind of therapy she's going to take. So including them all is important. And then one of the things that we did with the American Heart Association, as well as the American College of Cardiology, is really promote hands-only CPR as a graduation requirement for high school. So that meaning that it's no longer mouth to mouth, which would definitely be a taboo in India, but having the kids learn about CPR was essential, because in that process of them learning CPR, the teachers and the schools are able to talk about heart disease prevention. So they're all getting it at a young age. So we're starting with the very generational aspect to it as well.
Thank you. I think we have another question that's just come in on the chat. It says, I see a lack of understanding of the fourth trimester and care for women and the overall effects of pregnancy and women's health. Thoughts? So maybe this is for Dr. Valente.
Right, yeah.
Yeah.
No, it's a great question. I was thinking also, as Dr. Sharon was presenting, how wonderful that initiative is. And as I continue to train fellows, we're always trying to emphasize the importance of talking to a woman about her maternal history with regard to productive years. And I try to think about how can we continue to impress how important that is. And yet it may be that we need to even more so educate the individual women about that they need to be advocates and tell us when they've had hypertension in pregnancy, when they've had a premature birth or something else, because that idea of pregnancy as a stress test to your heart and a window of opportunity, it cannot be underemphasized. But I think I'm learning now it can't just be one pathway. It can't just be the cardiologist or just the obstetricians. We really, the more we can involve the families, and I think Dr. Mehta's point about involving the men in this discussion too, as sometimes the people that do make decisions. We can do a lot better, but I think we will do a lot better. So that's the good news.
And Sunita, I just want to add something.
Yes.
Talking to women during pregnancy, there's one more benefit, which is for their next pregnancy, which is really the low-hanging fruit. That if we are able to talk to women in the inter-pregnancy period, because this one becomes preconception for the next. So that's really the lowest hanging fruit, and all prevention strategies so far, including for gestational diabetes, has only worked in the prevention of recurrent GDM.
Yes.
Yeah, I think we really need a model for the fourth trimester, if we want to call it. We really need a model of care where it's not that at your 6-week postpartum visit, we say, hasta la bye-bye. It can't be. And I think that that's where the education piece has to come. And Dr. Valente, like you have a team, that team has to include the thereafter. And it needs to be the internist, the cardiologist, the obstetrician, all involved in that, let's call it aftercare. And that we have to make a plan for the patient thereafter, that we can't just be lost to follow up.
I'm so glad that that was a question that was asked, because the fourth trimester actually is an incredibly important time of a woman's pregnancy life, because it is that time when cardiovascular disease can be detected, such as postpartum hypertension and postpartum diabetes. And so we actually have been advocating in our legislature to increase the coverage of postpartum care, because it was only up to 3 months. In Illinois, we were able to increase coverage of a woman's postpartum care to 1 year, because we had such strong advocates here in Illinois. And we are trying to increase the coverage for healthcare insurance for women to be followed for a year after pregnancy, because that is such an important time to uncover those hypertension and diabetes.
Dr. Maheshwari, one comment, since Dr. Volkman brought up insurance. One of the things that's different in the U.S. these days is that when a person is employed, many of them have health insurance through their employer, and the employers now really push for preventative screening at the health sites. And so screening blood pressure, their sugars, their lipids, their waist circumference. And that I'm not sure is necessarily being done in India or not. But if it isn't, it's a low-hanging fruit for all men and women to be screened, because unless they get their blood pressure checked, they actually see someone to get it checked. They don't know they have these risk factors, and they don't know that their sugar's uncontrolled or they have lipids unless they're getting it checked. So that's another potential employer-directed preventative steps.
No, that's a good point. I think in India, the insurance so far has been very much hospital driven. They pay for admissions and so on. But just in the last year, we have what's called outpatient insurance that has begun, which will, pay for your doctor visits. And so encourage people to really get those checks before. So, I guess we have a long way to go, but it's been really great hearing you all. And I know there's a large Indian audience of doctors that have watched this and will, watch it on YouTube later. So a lot of lessons for us here in India to take home into our practices and hopefully into public policy as well. So I think, if there are no more questions, I'll leave it to Dr. Kamal to wind up the session for us. And thank you all on our behalf.
So I want to thank the AHA for sponsoring this wonderful event. I think that we've all learned so much. And again, I want to thank our panel of physicians for their time and contributions. I think the takeaway is that we all have a lot of work to do, but it is doable, and that our job is to help educate women and men on the risks of heart disease, stroke, and diabetes, and how important wellness is. And wellness really starts from childhood. So it's a co-pilot of parents and children through pregnancy, through the mature woman, and that the collaboration of the entire team and with our researchers like Dr. Goldstein, that together hopefully we'll have a better understanding of the COVID situation that we have, and at the same time, hopefully provide women and men with guidance for better care throughout their lifespan. And so hopefully we will continue these wonderful stimulating lectures with the help of the AHA and other organizations. And I thank everyone for their time. And if anyone has questions in the audience, they still may be sent to us, and they will be answered electronically. So on that note, thank you, everyone. Have a wonderful evening and day. And I think we all learned a great deal, and this was an extremely enjoyable conversation. Have a good day.
Thank you
very much.
Thank you, everyone.
Ciao, ciao. Thank you. Ciao, ciao.